about this image? So shape, what do you think of the shape?
It's still kind of oval.
Yeah, it's pretty oval, right? We can't see the flow. What do we think about the architecture? Little follicles, so maybe more lymphadenitis. Yeah, I agree. I agree. What about this one?
That's good. Yeah. Malignancy versus necrosis.
Right. But in the context of the case stem that I gave you,
So that's small growth.
like, you know, more likely to be abscess until we prove otherwise, right, with a failure to treatment.
And to answer your question from before, Nir, I think with this one, it's the clip begins, and you get that sense of, is all that stuff in the center pus? I think if you were to leave the probe in one spot and push, you would probably see a lot of those internal hepatic swirl, and that would be that like probe fluctuance that we were talking about.
So a little bit of pustulosis.
And you think this is tuberculosis?
This is tuberculosis?
Can you?
No. This is all you can tell is what you see. It's really, this is where it's important to have the context of the case you're seeing. If you were in an area that was endemic for tuberculosis, if the time frame fit, potentially, but
So
you'd have to
look like this.
Scrofulous can also go through a series of spectrums that can mimic. And I don't pretend to be an expert because we don't see a lot of it here, but my understanding is it can go through a similar kind of spectrum. What about this image? Right. I would argue you almost see a little pustulosis in this video, some swirling. Now, what else is kind of in this clip? What else is there beside the lymph node? Not a tray. Yeah, it's not a tray. Yeah. So the vessels are there, right? So if you think about where the cervical lymph nodes lie, what structures are there? Vein, artery, sitting right there, right? So when you look, one of the things we probably don't do enough of is when we look at lymph nodes and we see that they're big, or if we see that they're necrotic and they're anywhere close to the vessel, we should scan the vessel for thrombus and Lemierre's, because there's a potential that it could be there. Now, it's a rare thing, but while you're there, you may as well check it out. It's like going to the grocery store and picking up, some milk when you're getting cereal. You're there, so why not check it out?
What do you just like push with your probe? Like?
No, I wouldn't push. I would just kind of scan through and see if I see anything inside the vessel, especially if I see anything abnormal. You could put some flow on to see if you see normal flow. Yeah. But what you're really looking for is something that's abnormal around the site of the infection. Okay, so those are pretty simple kind of core concepts around the spectrum of disease. So then the question kind of comes up, well, what's new? What's new? So I think we've talked about before with ultrasound becoming more accessible. It's not uncommon, even in a site that has point-of-care ultrasound, for providers to go to ultrasound almost immediately, right? So if you have a non-POCUS trained person who's seeing this, anybody with a neck mass almost gets an ultrasound now. Would you agree? It's become kind of the go-to thing. And so the number of ultrasounds for neck has kind of gone through the roof. And this was actually a concern here at SickKids even as early as 2011, was that the number of neck scans was kind of getting out of control. Now, the hope was always that point-of-care ultrasound may help kind of temper that. But there's been this study just recently came out, and I think it's kind of helpful. So this is, again, a clinical decision rule. It hasn't been validated yet. It was done in Texas. And it was around the use of ultrasound in children preventing with acute inflammatory neck masses. And the question was really, does everyone need an ultrasound scan? Now, for us at the bedside, if we include POCUS as part of our history physical point-of-care ultrasound, we can use it. But we can learn a lot from this too, because they looked at 341 patients, done retrospectively, and they wanted to see who really got an early drainage and who could be sent home on antibiotics. And what they found was pretty clear. You can see the table there in the odds ratios. If you're older than 1 year of age, if you have swelling for less than 3 days, and if you have no fluctuance or erythema, then the chance of you getting a drainage is low. And their recommendation would be that if this is validated, this could be a guideline for us to start antibiotics and see who responds to antibiotics over 1 to 2 days, and that you don't necessarily need to image. Now, as point-of-care ultrasound providers, this just gives us a little bit of insight into kind of what we should anticipate seeing, and whether if we see something in this age group, whether or not they could still maybe benefit from some clindamycin or some antibiotic. But it's just something for us to consider, just something to think about.
I agree that it's very cultural. Like where I'm coming from, we use less ultrasound.
Yeah. So in Israel, maybe a little bit, you're going to wait till you have a higher suspicion. Here, there's a little bit
I found out like Dr. Sen's like,
yeah, absolutely.
Kids with an ultrasound after, like you said, 2 or 3, 4 days of swelling.
Right.
You also do ultrasound just to like have a diagnosis sometimes.
Yeah,
So like, is it just one node? Is it several little lymph nodes clustered together?
Right.
That's only because we want to do an IMD.
I agree. Like for us at the bedside, with the ease that we can do point-of-care ultrasound, I think we should include it as part of our physical and our history and physical. But I think it is interesting to think about who's going to need drainage and what we're really looking for. So, anyways, I think this is pretty cool. I think it's pretty simple when we think about this really short term, and it's the future, I think, to really do this well. And again, the key things, we're looking at shape, we're looking at flow, we're looking at architecture as we look on that spectrum of infectious from early to late in abscess. Okay, so now we get into the stuff where I have to throw out a bit of a warning, because I think that, this is the part that we haven't explored so much, and we need to talk a little bit about scope creep and what really our role is, and we'll come back to that. Let's go on to case 2, having given you that warning. So this is a 16-month-old female, complained of right-sided lump for 6 weeks. History of viral illness on onset. Now the mass is larger. It's unresolved despite antibiotics for 2 whole weeks. No fever or pain. These are the vital signs. And when you do the ultrasound, this is what you see. So thinking back to what a normal lymph node looks like from our very first slide, what do we think about this one? It's larger. Just soak it all in, and I'll show you what it looks like with flow on it in just a second.
You don't know the size.
It's
The shape is oval.
ovoid. You don't see the regular aperture.
Yeah, architecture.
You don't see the island.
Here's the flow. Right. So what would you be concerned about? Malignancy, right? So I think this is where it's really important to think about the piece of the puzzle. We joke about that a lot, but I think it's really important to put things in context. So we have size. So normal size would be a centimeter and a half at the mandible. The duration, so we kind of break down duration as 2 weeks as being acute, 2 to 6 weeks as being subacute. And after 6 weeks, that's really, we're outside of what we would typically think of as being normal for infection or inflammation, although there are some disorders that can kind of come and go. Now, does that mean that you can't have a presentation of a cancer at 2 weeks? No, but it does help guide us a little bit. So when we think about what is concerning for malignancy, there are some factors, and I'm going to read them here so I don't miss any, and I want you to think about them. So anything over 2 to 2.5 centimeters in size, if it is firm and hard in consistency on exam, if it has a supraclavicular or axillary location, if it's at the posterior edge of the sternocleidomastoid muscle, if there's absence of tenderness, which I think is easy for us to assess. If there's low mobility, so it doesn't move very much. And if there's really a progressive course, so progressive course despite antibiotics. And then of course, B symptoms. And when we talk about B symptoms, people kind of banter around, but that means like sweating to the point where your sheets are drenched. And weight loss is defined as, I think, 10% of body weight over 6 months. So we need to put those things into context. That's why the history is so critical in looking at these images. Okay.